Hi, my name is Dr. Hussein Hadi from the Department of Pathology and Forensic Medicine at Mustansiriya University. Today I would like to talk about the heart diseases from the pathological point of view. It will be in a series of 4 lectures. Today I would like to talk about the heart failure and the congenital heart disease, and with the other lectures I will try to talk in brief about the ischemic heart disease and valvular heart disease, the myocarditis and cardiomyopathies, and hopefully about the pericardial disease, and finally about the tumor of the heart. To start with, we need to know that the average weight of the heart is 250 and 350 grams, and the normal thickness of the right ventricular wall is zero point 0.3 to zero point 0.5 centimeter, whereas the normal thickness of the left ventricular wall is about 1.3 to 1.5 centimeter. That means the left ventricular wall is thicker than that of the right ventricle. In addition, we need to know that the cardiovascular system is the first organ system to become functional in utero at approximately 8 weeks of gestation. The cardiovascular disease is the leading cause of the death worldwide, and there are 6 principal mechanisms through which the pathophysiologic pathways result in the heart disease, and these are: first, failure of the pump, which cause either systolic dysfunction or diastolic dysfunction. When we say systolic dysfunction, the cardiac muscle contraction weakly and the chamber cannot empty properly, whereas in some cases the muscle cannot relax sufficiently to permit vascular filling, resulting in diastolic dysfunction. The second principal mechanism that result in heart disease is the obstruction to flow. The third one is the agitant flow. The fourth one is the shunted flow, and we have of the cardiac conduction, and finally of the heart or the major vessels. Now I will try to talk about the heart failure in more details. When we said the heart failure, it is often referred to congestive heart failure, and is the common endpoint for many forms of cardiac disease, and typically is a progressive condition with a poor prognosis. We need to know that the onset of congestive heart failure is sometimes abrupted, and in other cases, however, the congestive heart failure develops gradually. The heart failure is a multi-system derangement, and this will lead to impaired cardiac output, resulting in the fatigue, impaired gas exchange in the lung, which causes shortness of breath, disturbance in the heart and salt balance, which resulted in edema, and finally changing in skeletal muscle function. The heart failure may result from either systolic or diastolic dysfunction. The cardiovascular system attempts to compensate for the reduced myocardial contractility or increased hemodynamic burden through several hemostatic mechanisms. We will talk about such hemostatic mechanisms in more details. First, we will talk about the Frank-Starling mechanism. The Frank-Starling mechanism increased end diastolic filling volume, dilated the heart, and causes increased cardiac myofiber stretching. These length fibers contract more forcibly, thereby increase cardiac output. If the dilated ventricle is applied to maintain cardiac output by this means, the patient is said to be in compensated heart failure. However, ventricular dilatation comes at the expense of increased wall tension and magnifies the oxygen requirements of an already compromised myocardium. With time, the failing muscle is no longer able to properly and sufficiently propel blood to meet the needs of the body, and the patient develops decompensated heart failure. The second compensated mechanism is called the activation of the neurohumoral system, and this includes first is the release of the neurotransmitter norepinephrine by the autonomic nervous system and increased heart rate and will increase the myocardial contractility and vascular resistance. Secondly is the activation of the renin angiotensin aldosterone system promotes water and salt retention. And the third one is the release of atrial natriuretic peptides and act to balance the renin angiotensin aldosterone system through diuresis and vascular smooth muscle relaxation. The third compensated mechanism we have, which is called the myocardial structural changes. The myocardial structural changes including augmented muscle mass. Cardiac myocytes adapt to increased workload by assembling new sarcomeres, a change that is accompanied by myocyte enlargement, and this is called the hypertrophy. You can notice from this figure the left ventricular hypertrophy, and the left ventricle is on the left right in the apical four chamber view of the heart. The pressure hypertrophy is in this case is due to left ventricular outflow obstruction. We need to know that there are two types of the hypertrophy. First is the when there is an pressure overload state, for example in hypertension or valvular stenosis, and there will be new sarcomeres tend to be added parallel to the long axis of the myocyte, adjacent to the existing sarcomeres. So the growing muscle fiber diameter results in which is called the concentric hypertrophy. So and the ventricular wall thickness increase without an increase in the size of the chamber. And you can here in the concentric hypertrophy of the left ventricle, and this is a cross section of the heart with marked concentric thickness of the left ventricular wall. You can notice corresponding decrease in the ventricular cavity. The best example of it is the systemic hypertension. We have also the another type of hypertrophy, which is in volume overload state. And for example, the best example of it is the valvular regurgitation or shunts. In this case, the new sarcomeres are added in series with the existing sarcomeres so that the muscle fiber length increase. Consequently, the ventricle tends to dilate it, and the resulting wall thickness can be increased, normal, or decreased. You can notice in this figure all of it part. While on the left side of the picture, mass and thickness of the left ventricular wall, while the hypertrophy and the dilated heart on the right side has increased mass and normal wall thickness. So, in the center of the picture is the normal one. The left side is the pressure overload state with the increased mass and thick left ventricular wall, and on the right side is the heart with volume overload state with increased mass and with normal wall thickness. We need also to know that the heart failure could be resulted from the volume loaded hypertrophy increased by the regular aerobic exercise, and this is called the physiologic hypertrophy, which is typically is accompanied by increase in capillary density with decreased resting heart rate and blood pressure. Now we need to know that the heart failure has two types, either the left-sided heart failure or the right-sided heart failure. For the left-sided heart failure, the most common cause of it is the ischemic heart disease, hypertension, third, mitral or aortic valve disease, and finally the primary diseases of the myocardium, for example, amyloidosis. The morphologic and clinical effects of the left-sided congestive heart failure stem from diminished systemic perfusion or from the elevated back pressure within the pulmonary circulation. For the left-sided heart failure, we already know the causes of it, and now we will talk about the morphology and the clinical feature of it. For the morphology, first, for the morphology of the heart, grossly depends on the underlying disease process, for example, myocardial infarction or valvular deformity. The left ventricle usually is hypertrophied and can be dilated, sometimes massively. And for the microscopic changes in heart failure are non-specific, consisting primarily of myocyte hypertrophy with interstitial fibrosis of variable severity. We talk about the morphology of the heart, and now we will move to the lungs. In the lungs, there will be rising pressure in the pulmonary veins is ultimately transmitted back to the capillaries and arteries of the lung, resulting in pulmonary congestion and edema. The lungs are heavy and boogy. Microscopically, we will see First, perivascular and interstitial transudate. Second is alveolar septal edema. Third is the accumulation of the edema fluid in the alveolar spaces. And in the chronic heart failure, we will see the which is called the hemosiderin-laden alveolar macrophage, and this is called the heart failure cell. The heart failure cell is resulted from the variable number of RBC extravasated from the leaky capillaries into the alveolar spaces where they are phagocyted by the macrophage. The subsequent breakdown of the RBC and the hemoglobin leads to the appearance of the hemosiderin-laden alveolar macrophage, so-called heart failure cells. In this figure, you will see the pulmonary edema in the case of left heart failure. You can notice the prominent congestion capillaries and the faint staining edema fluid filling the alveolar spaces. The next figure will show the chronic venous congestion of the lung. On the left side is the low power, while on the right side is the high power view. You can see the engorgement of the septal capillaries and also the hemosiderin-laden macrophage, the hemosiderin granules within the cytoplasm of macrophage, which appears as brown discoloration. We talked about the left-sided heart failure in regard of the causes, morphology, and now we will talk about the clinical features of it. And this include first, which is called dyspnea. So the patient will present it with dyspnea, which is the shortness of the breath on exertion, mainly in physical activity, which is usually early and most significant symptom. Secondly is the cough, which is also common as a consequence of a fluid transudation into the air spaces. We have also the orthopnea, which is dyspnea on lying down. Paroxysmal nocturnal dyspnea is particularly dramatic from the of breathlessness, awaking patient from sleep with extreme dyspnea and feeling of suffocation. The patient could also presented with retention of salt and water with consequent expansion of the interstitial fluid and blood volume. Finally, in severe congestive heart failure, diminished cerebral perfusion may manifest as hypoxic encephalopathy marked by irritability, diminished cognition, and restlessness that can progress to coma. Now we will move to the right-sided heart failure. The main cause of the right-sided heart failure is usually a consequence of the left-sided heart failure. Another cause of isolated right-sided heart failure is infrequent and typically occurs in patients with one of a variety of disorders affecting the lung, parenchymal lung disease. Hence, it is often referred to as carpal tunnel. The carpal tunnel also may arise secondary to disorders that affect the pulmonary vasculature. The major morphologic and clinical effects of the pure right-sided heart failure differ from those of left-sided heart failure in that the engorgement of the systemic and portal venous system typically is pronounced. Secondly, the pulmonary congestion is minimal. Now we will talk about the morphology on the right-sided heart failure. In addition to the cardiac changes, which is noted as hypertrophy and dilatation, generally confined to the right ventricle and atrium, other organs principally affected by the right-sided heart failure include liver and portal system. In liver and portal system, the liver is usually increased in size and weight, and this is called the congestive hepatomegaly. The cut section display prominent passive congestion, a pattern referred to as nutmeg liver, which is appear as mottled appearance, as you can notice in this figure. In chronic venous passive congestion of the liver, the cut surface shows mottled appearance. In it, the dark areas represent the congestion around the central veins, and this alteration has been linked to the cut surface of a nutmeg, and this is called the nutmeg liver. When left side heart failure is also present, severe central hypoxia produces centrilobular necrosis in addition to the sinusoidal congestion with long-standing severe right-sided heart failure. The central areas can become fibrotic, creating so-called cardiac cirrhosis. The right-sided heart failure can also lead to elevated pressure in the portal vein and its tributaries, and this lead to which is called the portal hypertension, with vascular congestion producing a tense enlarged spleen with congestive splenomegaly. We can notice in the right-sided heart failure other organs could be affected, and other spaces, which is mainly the pleural, pericardial, and peritoneal spaces with the systemic venous congestion, can lead to transudate effusions in the pleural and pericardial spaces, but usually does not cause pulmonary parenchymal edema. A combination of hepatic congestion with or without diminished albumin synthesis and portal hypertension can lead to peritoneal transudate and lead to ascites. The subcutaneous tissue could be affected and cause peripheral edema of the dependent portion of the body, especially of the feet and lower legs. We talked about the causes and the morphological point of view of the right-sided heart failure. Now we will talk about the clinical features. The clinical manifestations are related to the systemic and portal venous congestion and include first the hepatic and splenic enlargement, secondly is the peripheral edema, third is the pleural effusion and ascites. When the kidney and the brain is affected, there will be deficit which is comparable to those caused by the hypoperfusion of the left side heart failure. As the congestive heart failure progresses, patient may become frankly cyanotic and acidotic as a consequence of decreased tissue perfusion, resulting from both diminished cardiac output and increased congestion. In this figure, you will see the pitting edema in the right-sided heart failure, mainly in the ankle region, which is observed as swelling of the body tissue due to fluid accumulation that may be demonstrated by applying pressure to the swelling area. And this is forming which is called the pitting edema. The figure of such patient show the huge distension of the abdomen, and this is called the ascites, and this patient has right-sided heart failure secondary to lung disease. Now we will move to the other heart disease, which is the congenital heart disease. The congenital heart disease are abnormalities of the heart or great vessels that are present at birth. They account for 20 to 30% of all birth defects and include a broad spectrum of malformations. Congenital heart disease affects nearly 1% of newborns. The incidence is higher in premature infants and in still. The most common are in descending order of frequency. First, we have the ventricular septal defect, which account for 42%. Then the atrial septal defect, pulmonary stenosis, patent ductus arteriosus, coarctation of the aorta, and finally the tetralogy of Fallot and transposition of great arteries, which account for 1%. We need to know the pathogenesis of the congenital heart disease. The congenital heart disease most commonly arises from faulty embryogenesis during gestational weeks 3 through 8, when major cardiovascular structures develop. The cause is unknown in almost 90% of cases. The accepted etiological factors are first, environmental exposure, including congenital rubella infection, teratogens, and maternal diabetes. Secondly is the genetic factor, including specific loci implicated in familial forms of congenital heart disease, and certain chromosomal abnormalities, for example, trisomy 13, 15, 18, and 21, and Turner syndrome. We need to know also the mutation in the intracellular signaling cascade, microRNAs, as well as epigenetic changes may play a role, also are increasingly recognized as important contributors. For the clinical feature of the congenital heart disease, the structural anomalies in congenital heart disease based on their hemodynamic and clinical consequence can be seen as first, malformation causing a left to right shunt. Secondly is the malformation causing a right to left shunt, which is called the cyanotic congenital heart disease. And third one is the malformation causing obstruction. In this lecture and hopefully in the next one, we will talk about such malformation in more details. For the malformation causing a left to right shunt, the best example is the ventricular septal defect, atrial septal defect, and patent ductus arteriosus. And for the malformation causing right to left shunt, we will take the tetralogy of Fallot and transposition of great arteries as an examples. And finally, for the malformation cause and obstruction, we take the coarctation of the aorta as an example. We need to know the shunt is an abnormal communication between chambers or blood vessels and depends on the pressure relationships Shunts permit the flow of blood from the left to right side of the heart or vice versa. So, accordingly, we will see the malformation associated with left to right shunts. And they are the most common type of congenital cardiac malformations, including, as I said, ventricular septal defect, atrial septal defect, and patent ductus arteriosus. This figure, we will see the common congenital causes of left to right shunt, mainly the VSD in the lower right and the patent ductus arteriosus and the atrial septal defect, and the arrows indicate the direction of blood flow. In the atrial septal defect and the flow of blood from the left atria to the right atrium, and in the lower left you will see the VSD and with the flow of blood from the left ventricle to the right ventricle, and finally for the patent ductus arteriosus. Atrial septal defects typically increases only the right ventricular and pulmonary outflow volumes, while ventricular septal defect and patent ductus arteriosus causes both increased pulmonary blood flow and pressure. Manifestation of these shunts range from completely asymptomatic to fulminant heart failure. Cyanosis is not an early feature of these defects. However, prolonged left to right shunt may eventually give rise to pulmonary hypertension and right to left shunting of unoxygenated blood into the systemic circulation, a change marked by the appearance of cyanosis, and this is called Eisenmenger syndrome. Now we will talk about the ventricular septal defect, which, as I said, it is one of left to right shunting, and constitute the most common congenital cardiac anomalies at birth. The ventricular septum normally is formed by a muscular ridge that grows upward from the heart apex, fusing with the thinner membranous partition that grows downward from the endocardial cushions. The basal membranous region is the last part of the septum to develop and is the site of approximately 90% of the VSD. Only 20 to 30% of the ventricular septal defects occur in isolation. The remainders are associated with other cardiac malformations. For the morphology, the size and location of ventricular septal defects are variable. In the presence of a significant left to right shunt, the right ventricle is hypertrophied and often dilated. Pulmonary artery is dilated due to the increased right ventricular output and higher right-sided pressure. Vascular changes typical of pulmonary hypertension are common. In this figure, the ventricular septal defect of the membranous type seen in the arrow, there is an incomplete closure of the ventricular septum. Clinical feature, it depends on the size of the defect. The smaller VSDs may be asymptomatic and close spontaneously during infancy or childhood. Larger defects results in chronic left to right shunts, often complicated by pulmonary hypertension and congestive heart failure. Progressive pulmonary hypertension with resultant reversal of the shunt and cyanosis, which is called the Eisenmenger syndrome, occurs earlier and more frequent with ventricular septal defects than with the atrial septal defects. Early surgical correction is therefore indicated for such lesions. Small or medium-sized defects that produce jet lesions in the right ventricle cause endothelial damage and increase the risk of infective endocarditis. These are some suggested reading and hopefully you will find it useful for you. Thank you.